Mark Blaxill is the co-founder and executive director of XLP Capital, a firm founded in 2015 and focused on technology strategy development, advanced data analytics, and technology-based investments. Before starting XLP, Mr. Blaxill was a co-founder and managing partner of 3LP Advisors, a firm focused on IP strategy development, patent transactions, and IP-based investments. Previous to the launch of 3LP in 2008, he was a 25-year veteran of the Boston Consulting Group, where as senior president and partner, he headed the firm's strategy practice and recruited BCG's core IP strategy team. In this role, he launched the firm's intellectual property practice, developed proprietary tools for technology analysis, and co-authored BCG's first patent application. He is the co-author of The Invisible Edge, Taking Your Strategy to the Next Level Using Intellectual Property, Portfolio 2009, which was named, it was in Portfolio in 2009? That's the publisher, okay, sorry. I know nothing about investment or intellectual property. Okay, moving on. Okay, so at least I have your bio, right? Yeah, at least you did. He has been named one of the world's leading IP strategists by IAM Magazine. Mark credits that honor to XLP's unique integration of the quantitative analyses of technology, patents, business, and financial performance. Mark is also the father of a daughter diagnosed with autism, chairman and co-founder of the Canary Party and Health Choice, editor-at-large for Age of Autism, a former director of Safe Minds, and a frequent speaker at autism conferences. He writes often on autism, science, and public policy issues for the Age of Autism and has published a number of articles and letters and commentaries on autism in many journals. I'm not going to read them all, sorry. Mr. Blaxill earned an MBA with distinction from Harvard Business School and an AB from Princeton University's Woodrow Wilson School of Public and International Affairs, where he graduated summa cum laude and Phi Beta Kappa. So highly credentialed and a good friend. Welcome, Mark Blaxill.
Hi, everybody. I keep the business stuff in because it does create a different lens on this world. And my life changed when my daughter was diagnosed with autism back in 1998, literally a few months after Andy's infamous paper. But being a business person and a health choice advocate or health freedom advocate, it's a lonely place in the world, but it does create a unique perspective. I want to tell a little story today about this paper, and there are two dates on this front page of the PowerPoint. One date is the date Amy Becker and I actually released an analysis that we did of some CDC data. And Amy was a fellow traveler, also a business analyst, works for a marketing company. And I'd known Amy for years, and when the whole COVID thing started, I was wondering about what was really going on. And Amy was actually going to the source to get a lot of interesting data, and you'll see some of it. And she shared snippets of it on Facebook, and I just said, Amy, that's the right thing to do. I'm really interested in what you're doing. Let's look at this. And we started watching it. It was late March, early April. And then we were tracking the data, and there were all sorts of things. We were asking questions, and we wanted to wait for a while because there were definitely reporting lag issues, and I'll talk about that. But we figured, and so it took us until June to finish this conversation because we were confident enough in what we had seen that we felt like, well, maybe the numbers will change, but the conclusions won't change fundamentally. So we put that out there, and so today is the first time I've actually shared some of the updated data, because it's been about 3 months since we actually sent this out there. Good news is nothing radically changed. So the basic lesson, which is in the subtitle, which is that a lesson from the lockdown is that fewer infants are dying. But it's the first time to share some of the lessons that I've learned, and the good news is that that stayed the same. The bad news is that the initial data suggested we were largely past the worst of COVID, and we're not quite there yet. So, and I'll explain. So we put this paper out in June. I did some interviews. I was on Highwire, which was a lot of fun. Dell did a great job. And then within a few days of actually starting to do interviews, this showed up on the Facebook link that we used to get that out. I got fact-checked, and we knew this was coming. And it's interesting, there's a lot of data in the white paper, and some of it's changed, and some of the conclusions were mostly right, but informed by additional data. But the reason that we were fact-checked was not for the things that were more notably revisable, but for one fact that stayed pretty much intact, which is that fewer infants are dying, in large part, I believe, because mothers aren't taking their children to the pediatrician to get their shots on time. And so we're seeing fewer, the speculation is that we're seeing fewer SIDS deaths. That's the reason we got fact-checked, and they said, well, there are two reasons why this report is partly false. It wasn't entirely false. It was partly false, and one is all that stuff about infants not dying is just reporting lags, and the second reason is vaccines don't cause SIDS. And we know that, and so we can just dismiss that idea out of hand. The vaccines don't cause SIDS. I knew that was coming. In fact, I was the one who argued to put that line in the paper to suggest that, because we know that some doctors were pointing that out. But I was actually a little worried that somebody knew something I didn't know about reporting lags, because that was the thing that we were worried about, the timing of the release. So I'll tell you what we learned about reporting lags, because there are some, but they didn't change the conclusion. So let me tell you a little bit about the paper and our methods and our findings. I think the thing that got Amy and me talking about this data was that there's a lot of data coming out, and there's tests, and there's positives, and there's cases, and there's beds in the ICU, and there are deaths that are COVID deaths, or maybe they're not COVID deaths. The old joke about someone who fell out of an airplane without a parachute and died, and COVID goes on their death certificate because they tested positive. There's a lot of data out there, and to me, it's a little bit like the vax-unvax study. The bottom line is overall health outcomes. If you get vaccinated, you want to know about a child, not whether they got measles, or not whether one child somewhere in the world died because they got measles, but you want to know what the total outcomes are for entire populations, comparing vaccinated and unvaccinated populations. With respect to COVID, I don't particularly care if someone gets an upper respiratory infection. That's not an issue. People get colds. Coronaviruses are a cause of colds. The issue is there some new thing that's happening that's causing people to die at excessive rates? And if that happens, that's important. But if it doesn't, why are we so concerned? And I was initially very skeptical that there was something wrong here, but I didn't know. And to me, this was what Amy was doing. She was looking at all-cause mortality data, because that is data that the CDC releases on a weekly basis. They do it largely to track flu seasons, so it's all on the FluView database. And it struck us both that the best measure to look at outcomes, total health outcomes, in the middle of the pandemic is all-cause mortality, not these selective measures, but rather weekly progress. If you had daily, that would be interesting. And then compare the pandemic period to prior years. And so that's what we do. And I guess the first thing I learned was that there's an issue. COVID is not a make-believe problem. If we're going to be balanced about it, the data show that there is a scale of an effect here, a variable effect, and there are negative outcomes, especially in elderly Americans, and that just I don't think they could make up this data. So we shouldn't understate the question, and I won't go into that here. Is why are we doing gain of function? Why is the NIH funding gain of function research in Chinese military laboratories? That's the question we should be talking about. I won't talk about that here. But there is a problem, and it's I don't think it's quite questionable that there is one. But the surprise, and this was part of our exploration, was that we were seeing rising mortality in the elderly especially. But when we looked at children, mortality rates looked like they're falling. And we also know, because there were articles written about this in front page stories, the vaccination rates were going down, and the pediatricians were worried about that. And that struck me as important, and that's why we got fact-checked. Methodologically, it's tricky, and we tried to keep it as simple as possible and just count deaths. We get weekly deaths. Death rates vary for a whole range of reasons. The biggest thing that drives differences in death rates is age. Old people, people die every day. That's part of the circle of life. Old people die at dramatically higher rates than younger people. Time of year causes some changes in mortality. That's why the flu season is where they track it, because the flu view website in the CDC is where they post the data, is because in the winter, more elderly people die of pneumonia-related illnesses, and that's just the way it is. Geographically, there are differences. There have been differences in COVID by geography. We don't know yet whether COVID will be cyclical, but there are a lot of differences by age and geography. So that's kind of the overview, but the interesting part is the journey on the, there are a bunch of interesting parts. Exploring the age differences and the geography differences are what intrigued us. The overall situation, and this is the data that we first published, it looks, and it's pretty much the same, is that COVID was a very sharp, clear impact on all-cause mortality in the United States for a couple of months in March and April. And there was and what this data does, by the way, every line is deaths by flu season. So the colors of the flu seasons are the same. And what you see is that generally there's the same amount of people die in the United States every week, and it varies a little bit by stage of the flu season. But during this flu season, in March and April, we had dramatically higher rates of death. And that's likely to be because something new happened. But, and this was the one thing that was a little discouraging, when we published the paper in June, it looked like we were back to normal. Updating it, we're not quite there yet, because there is a reporting lag. We, by the way, waited they publish data up to the current week. We took off the most recent 4 weeks in any of these charts because we were worried about the reporting lag. But it does appear that there is sort of a late stage reporting lag that catches up with you. And in the US, it almost went down to normal, and there's even been a little bit of a second surge, and I'll tell you where that's come from. So that's the current situation, which is still not normalized, and this is why we're still all locked down and masked up and and restricted from traveling, and it's a difficult situation. But if you look overall, and this is, and I didn't update all these charts. If you look at the U.S. overall, it is a sharp period on average, 30-40% higher than typical mortality in that one period, all almost entirely driven by the elderly, and then trending back to normal. If you look at what's causing it, it does appear to be pneumonia related, and these are the proportion of deaths. The top line is total deaths. The blue line is pneumonia and influenza deaths. Most of that's pneumonia, and that's driving that really sharp temporary spike.
Can you clarify really fast? COVID's not pneumonia.
COVID gets classified in with pneumonia and influenza deaths, upper respiratory thing. So they're putting that all in that same thing. Yes. And ultimately, someone who's in distress because of COVID, it's not because they got a coronavirus, it's because it overwhelms their immune system and their lungs. And so it's a respiratory, and it ends up classified as pneumonia for the large part. So, that is a thing that we learned, and I was skeptical of that, and I became more persuaded that there's a reality to the problem. But that's overall, that's on average in the U.S., and if you actually look state by state, there's enormous variation across the country. The overwhelming majority of the problem was in the northeastern seaboard, which is, as Kristen knows, is where I come from. I was born in New Jersey, lived in Massachusetts, and spent I got out of Manhattan last October, which I'm thankful for. And you look at the New York City, New Jersey, New York State, the rest of New York, Massachusetts. Those are at the top of the leaderboard, and you can speculate why these states were the worst. There are all sorts of reasons, but it was largely a northeastern problem. The United States average, and this number will click up some. It's probably 10 or on average, the United States death rate in this period through May was 105% of average mortality. If you take some of the updates more recently, it's probably more like 110, 115%. So it's not getting better yet, but it's still not the Spanish flu. But interestingly, there are some states that are below the average. There's some states where death rates are lower than they are in a typical year. If you look at the states that didn't go into lockdown, those are the yellow states, they're all below the average, and in some cases at the bottom of the list. So there's not a lesson that says lockdowns work. It's not a lesson that says the coastal elites are more virtuous than the rest of us. There are all sorts of complicated matters. There's a lot of variation and a lot of differences across states. By far and away, the worst place in the country was New York City. And it's important to emphasize all these charts. I often change the vertical axis. So in New York City, in 1 week, I think that's March, there were about 7,000 excess deaths in a single week. And so New York has had a huge problem. Yeah?
Was that when we started sending the COVID positive nursing home patients back into the nursing home?
That's certainly a contributing factor. If we get down the rabbit hole of trying to explain everything about COVID, I'll not finish in 35 minutes. But New York City has subways. It has more travel to China. It has it had some policy issues in terms of how they treated infected patients.
Mass murder in hospitals. Let's just acknowledge that it's not necessarily COVID. Sorry.
This is a lot of death.
Okay.
And I'm not actually going to sit back and say that this is normal.
No.
New York City was really, really heavily impacted, and it could be a whole set of things. But New York City, and by and large, that by April, it looked like on a positive trend. And the good news is, this is the updated data, and New York City should be back to normal. They're not yet back to normal. They're not open. They're not off lockdown, but they're inching up to that. But they went through a really horrible time, and they're largely past it. We did some analysis of Massachusetts and the rest of New York State, and a lot of them look basically like New York City. So the Northeast is past the worst of the COVID problem. What was interesting is that there were a lot of big states at the time, Florida, California, Texas, that didn't look like they had particularly, they were all on pressure to lock down and in the news. It didn't look, it looked like the biggest states were escaping the problem in that March and April period. The blue line, the green line, the gray line, Texas, they made it through the worst of March and April without serious issues. What's interesting, and you saw that there was this little tick up of deaths in my update, a lot of that is coming from these three states. The big states where death rates came late. Florida and Texas have ticked up, but it looks like they're a little past a tick up. California was high, started to come down a little bit, went back up high again. These three states explain almost all of that, what you might call a second wave. And so, there are issues in those states. And those states aren't particularly shy about lockdown. I mean, my oldest daughter lives in California, and they can't do anything, go anywhere, and they haven't gotten a lot better. Florida has been a diverse story. Texas, I think, has been in the news. Both of, and those are complicated situations. But a large part of the continuing problem is in these three large states, and all of these vertical axes are the same. So it's the same amount. You can compare the amounts of deaths in all of these, and they all add up to that little second surge in the overall numbers. What's interesting is that you look at the states without stay-at-home orders. Those are 5 states: Arkansas, Iowa, Nebraska, South and North Dakota. And through the first wave of analysis that we did, if the red line is the U.S. on average, they're all pretty much average or better than average relative to their history. And the good news is that in the update, and I couldn't fit all 5 states, and my co-author Amy has the model that does that chart, so I just did the basic data so you can see the states one by one. North and South Dakota, this COVID hasn't been a problem from the beginning, and it isn't a problem today. Things haven't gotten worse. Iowa ticked up a little, got better, it's ticked up a tiny bit, but pretty much the states that didn't go on lockdown, with the possible exception of Arkansas, are still in pretty good shape. So lockdowns don't create dangerous conditions where people can't live normal lives, and a bunch of our renegade states support that point. So that's, and I could go into greater depth, and there's some fascinating work that's done, and I think work that supports the idea that lockdowns don't solve everything. So that's the geographic perspective. What was most interesting as we got into it was the age cohort perspectives, and the CDC. It's worth noting we were going in with CDC data. They have 2 data sets. One of them is the influenza data set, which only breaks out age by 3 groups: 65 and older, 18 to 64, and under 18. They have an additional data set, which is maybe not quite as updated, that breaks information down into smaller age cohorts, and I'll show you both. I've only updated one of them. But the notion that COVID is dangerous for the elderly was one of the big findings. If you look at 65 and older death rates, and this is where you also see the flu effect. This is why they're tracking the seasonal flu death rates at CDC, and this is where the bow shape is, in the typical data, is the most pronounced. And it's also the situation where you saw the greatest anomaly with COVID, and that's if average death rates in March and April were like 40,000, we're seeing close to 60,000. So there's 20,000 excess deaths per week in the elderly with COVID. And again, the good news looked like that we were getting almost back to normal. Updating the data, we did find that reporting lag in the most recent numbers, and so it looks like there's, particularly California, Texas, and Florida, there's something that is ongoing, although we can hope that it's heading back down. Similar pattern in 18 to 64-year-olds. That looked like it was almost going away, but that also has held intact, although the effect isn't nearly as large as the elderly. It's important to recognize, though, it's old people that die at a higher rate. If you break down these birth cohorts by smaller groups, the top line is the death amounts for people 85 years and older, and that's far and away the largest amount of deaths in any given week. The next line down is 75 to 84. The third line down is 65 to 74. The next line down is 55 to 64. And the overwhelming majority of deaths in this country every week are people 55 degrees and older. And you go younger than that, and the death rates are generally flat, not affected by COVID one single bit, and quite low. So if we look at that 18 to 64 group, it's not 18-year-olds or 20-year-olds that are dying. It's pretty much the groups that are almost, that are in their 60s or above. So it's very unevenly distributed, and we are seeing an effect of, a risk that is weighted towards the elderly. These numbers have not changed. This is the updated numbers that, and Amy did run these. And so that's, kind of what we got to, which is not a revolution. No one. It's just interesting to me. Most of you know that already. That's not why we decided to write a white paper and send it out. Because one of the questions we started asking, and because we heard that because of COVID, pediatricians were starting to worry that children weren't being taken in for their well baby visits. And I said to Amy, Amy, we can break out ages, and she had already broken out the elderly. I said, why don't we look at children? And so we did, and this was the finding, the initial finding, which I will warn you in advance is a little too good to be true, because there were some reporting lags, but it's still true. The current flu season is that brown line, and we were surprised, and on average, very few children die. Children defined as anyone under 18. On average, 700 deaths a week among children, and that's from a range of causes, and I'll talk about that in a second. But this flu season, as far back as March, mid-March, the numbers started coming down, and we found that was interesting. I was looking forward to the opportunity to come do this because I waited until this week to update the numbers, and I did find that this was a little too good to be true, but we are still seeing that fewer children are dying. If you update the numbers, clearly in March and April, there was an effect where that brown line, it's about 90 or so deaths per week fewer than a typical flu season. It actually started returning to normal. So if you look at, if it was entirely explainable by reporting lags, that little dip in March and April would have disappeared by now. But in fact, it went all the way down, and it came back up in May, and then this, but still a little bit below average. This is a good year for children deaths. Children's deaths are much lower than they typically are. And then we had a discussion, although there may be a little, I wouldn't get excited about that more recent dip. Maybe the lesson for me is we should have waited 8 weeks instead of 4 weeks, because that line on the far right there, the brown line, may not stay with us. So then we had a debate about, with Amy and I, we started talking about, well, what does children mean? How do we know that this is vaccination, or the effect of possible vaccination? It could be teenagers, it could be fewer kids driving drunk, or it could be mom and dad are paying more attention to them now that they're home. There are all sorts of reasons you could imagine for lower children's deaths. And I said, no, Amy, I don't think that's true. I suspect most of those deaths are in infants. And sure enough, if you actually break out the children data, most deaths in children are infants under a year of age. And that's the blue line on top. 1 to 4-year-olds and 5 to 14-year-olds die at very low rates. We don't get that 14 to 17 group in this data set, so, but it's still pretty low. And in fact, most of that 700 deaths per week that you see in the under 18 numbers is explained by the 1 year and under, or the infant death rate, and that's held up with an update. So that number has continued to go down, although there may be reporting lag issues there as well. It's worth also noting that most deaths in infants a disproportionate amount of deaths among infants are children of color. If you look at deaths by age group, the orange bar in the middle is the white death rate, and a higher proportion of elderly deaths are in the whites because whites tend to live longer. You look at that under 1 year of age, second from the left, about over half of the deaths in infants are non-white. So if we care in this period of the Black Lives Matter protests about protecting the lives of children of color, addressing that disproportionate or embracing the drop in mortality among children and infants is a way to save Black lives, and particularly Black lives of infants. And so that's sort of what we found. We didn't go into the vaccines cause. We had maybe 2 sentences in the whole piece on SIDS, and basically reported what we've heard from some doctors that have not yet gone public, is that in a larger group practice of emergency room doctors, they were seeing fewer SIDS cases during the lockdown. And we asked the question, how could you get, in a very short period of time, a change in mortality? Could it be something else? Could it be a change in accidents? Well, if you look at what are the causes of death in infants, and this is, they don't give you the cause of death in any of these reports. They basically say, is there a death or not? But you can break out causes. There are studies, targeted studies, that break out the causes of death in infants, and SIDS is tied for first. And these other sources of death are not likely to change as much. Congenital malformation, perhaps accidents could change, and you could argue that circulatory complications or homicide. But we're driving to school less. A lot of the causes of these things might go in opposite directions. Homicides might go up, but SIDS is about 1/3 of all infant deaths. And if you had to come up with a causal hypothesis, is what could the lockdown change? It's not going to change these other things as clearly, and we know that the lockdown changed vaccination behavior. Why do we know that? Because the CDC has told us. This was a paper that came out in late April, early May. I think it was the May timeframe. And CDC reports vaccine purchases on the top, and those plummeted during the lockdown. That arrow pointing up The second one there is the national emergency declared in March, and immediately thereafter purchases went down. Obviously, pediatric practices were worried. People were not, stocking up or replenishing their stocks. Most interesting based on the update is that they also have they reported doses administered of MMR vaccine. And they report that for the first dose, which is the blue bar, and they report it for later doses, which is the gray bar. And as you can see, after the emergency was declared in March, those blue bars went way down. The later bars went down even further. And so we can observe directly from the data that around the time of the lockdowns, around the time we saw that dip, even in the updated data on infant deaths, vaccination doses administered were going down as well too. One thing I observed when we saw this the first time is, which makes more sense to me now, is that I would have thought that maybe that dip was more durable, but if you'll notice those blue bars, they went down into the the third and the fourth week of March, but thereafter they started going back up again. And so if you remember that bow in the updated curve, it may be that and we know that they observed this. They were heavily publicizing, trying to get kids back for their well baby visits, and so maybe there's even some catch up going on for kids that missed earlier vaccines. And that those blue lines are going back up, which would tend to support what we saw is that the mortality benefit started going away pretty quickly. So that's why I say, it was a little too good to be true. We do see a mortality benefit. It could have lasted longer. We could have gotten more benefit from the lockdown. What we should get is the benefit of retrospection and reflection, which is that if they're really going to analyze this data and take all the lessons from the lockdown, I think this is one that, the effect on infants and the unexpectedly better outcomes for infants is certainly a lesson that we should take away. That's basically all I have. I have time for questions. Yes.
I'm curious, did you see any difference in deaths in the states that did not lock down, like among the children?
Yeah, that was in there. No,
I missed it.
I'll go back to it.
Okay.
For just the infants.
Everybody asked this question.
Yeah.
What they give you, they'll give you by age, and they'll give you by state.
Okay.
They won't give you breakdowns by state and age at the same time. They have that data. They can do that. I am pretty certain that almost all of the worst impact in New York City was in the elderly. I have a 90-year-old uncle who is in an assisted living facility in Lower Manhattan. I was worried about him. And he's fine. We're celebrating his 89th birthday this coming weekend. But they don't give us that data, and everybody. And it's just the way the CDC, this is a public data set. It's updated every week. You can go online and find it. Anybody can do this analysis. You can download the data yourself. That's another very good question. Who was it that was suggesting we do this? Is that, Toby Rogers was suggesting that it's an interesting idea to go state by state, and maybe with FOIA requests, you could find out this data in your own state.
We second the suggestion.
Yes. I have a day job, and I did this. I don't update it every week. I don't do this full time, but I think that's a plausible scenario. I don't know how closely they'll keep this data. Yeah.
Did you by chance go back to like the 2009 flu season when they have H1N1?
They don't give us that data. No. I'd love to have more. Yeah.
In what ways did this data surprise you? In what ways did it
Honestly, I went in with the hypothesis that COVID's no worse than a typical flu season. And these are typical flu seasons, and it's worse than a typical flu season. So that was what surprised me the most. And then I held the hypothesis that, the infant effect wasn't the first thing we were looking for. We were looking to say, COVID. Now whether to trust the updates, because to the extent that we point the CDC to this finding, maybe they'll discover new deaths that they never knew about before among infants, and all those numbers will go back to 700. I wouldn't put that past them. But the surprise to me was, number one, the scale of the impact, the variability of the impact, number two, and number three, the benefit to children.
I know this gets into conspiracy theory territory, but I'm going to take you there.
All right.
All I need is a yes or no.
Okay.
When you were doing this study, did you ever take into account the federal funding that these places were getting to label pre-existing conditions, COVID?
We don't, there are, no. No. I mean, I know that's an issue, but there is nothing in this data that speaks to that.
How would you have tested that? How would you have gotten that?
This data doesn't give you the capacity to test that. Okay. I'll take the last question. I'm sorry, I'm getting...
So just in relation to New York City, so
Yeah.
we lived there, we're in New York City, and for one thing, New York City, like Wuhan was the first city in the world to be covered by 5G. And then
5G.
And
That's
then
the question.
New York City was the first city, along with Salt Lake City, that was where 5G was brought in. So those things, many people say lower the immune system. But also, so when we were living in New York City, 3 times the whole city was sprayed with malathion for the encephalitis. So all those things lower. And then we were looking at life insurance. So for years, for decades, your life expectancy, if you live in New York City, is 10 years lower. So, they could use these arguments. There's noise pollution. They could use these arguments against lockdowns.
I think the fact that the worst fatality rates in COVID are in the northeastern corridor is a very interesting question. What is the additional environmental exposure that might compound, a nasty Frankenvirus? Those are plausible hypotheses. Thank you.